So some of the key areas where we'll be focusing our care, mobility. And probably the most important thing with mobility will be that we want to maintain independence and make sure that someone is independent for as long as possible. Within the system that we work within and the constraints of the A&EP program, we sometimes have to be a bit sort of anticipatory of someone's potential needs. So we might know that the wait list for a motorised tilt and space wheelchair is 2 years long. Patient on the outset doesn't quite need it, but we might want to start putting in the back of our mind that they're probably going to need it. And on that clinical presentation work out, okay, well maybe we can start looking about where we can source some equipment from, popping in some early applications, rather than getting into a situation where the patient's gone off their legs and we're all of a sudden stuck sort of looking for equipment. But again, often working interdisciplinary and looking at some of these mobility issues. Like it might be the physios work with the OTs to work out, okay, we can get them a motorised wheelchair, but they're probably going to need to have some environmental controls, so the two work together. It's often highly specialised seating that we ultimately need as well, so it usually is clinician-driven and clinician-prescribed. Identifying when people need splinting and Botox, and flagging that, okay, this is a patient who's got maybe some significant contractures that's preventing issues with personal care. Making sure that we flag them to our Botox clinic and that the Botox actually occurs in a timely way before we hit crisis point and we can't position someone. Speech pathology in all of these illnesses is incredibly important. Probably most importantly, maintaining communication and often putting communication strategies in place early on and introducing stuff early on. Managing swallow and secretion so that we can maintain nutrition. And often linking someone with a speech pathologist early on, even if they don't have any pressing speech issues initially, so the speech pathologist can get a baseline is often quite important. And that relationship is often a very intimate relationship because working out some of that really fine, complex secretion management stuff that speeches are so good at doing is such a hard thing to actually do. Patients need to have time and they often need to really have a good rapport with their therapist. When we're getting to difficulties with swallow, when someone enters a discussion and sort of says, oh, problem with swallow, just have a peg tube. We need to make sure that those discussions are actually very carefully managed. And often, again, that's a team discussion because all have different takes on what the patient's sort of view is. And so often sitting down as a team and having a discussion around that thing, that issue, so that we can actually approach the issue as a unified team to support the patient through what their decision is, but also to help the patient make the decision that's most clinically appropriate. Particularly in the acute care sector, reaching for a peg tube is something we do very quickly. It's not necessarily appropriate. And just popping a peg tube in because someone's presented with dysphagia to the emergency department doesn't fix things. So again, maybe some anticipatory sort of work, making sure that we understand what the implications of the treatment are, and we've got decisions made before we get to a critical point so that if that happens, the patient can, or the family can say, actually, we've already made a decision, that's not going to happen. Continence. I'm a nurse. Really important. And continence is often if someone's still in a home care setting, is often, when continence is significantly affected, is often the straw that breaks the camel's back. People can often put up with someone who they're having to spend hours preparing food and overfeeding and lots of hard work positioning and getting someone comfortable. But the minute they're having to deal with wet beds, it gets to be really quite complex. Because of the autonomic nervous system impact of these diseases as well, we also need to understand that we might need to look at things such as self-catheterisation for urinary retention if we've got residual volumes over 100 mils to minimise that risk of urinary tract infection. We might have to look at permanent catheterisation later on, which is mainly related to bladder dysfunction. It's not actually a continence management strategy. Look at managing nocturia, and we might need to use some medications to manage nocturia. And we might need to put some really good continence measures in place. So if incontinency has become an issue, get some quality continence products, pop them in place so that it's manageable, as opposed to a crisis situation. And managing continence also helps sort of promote someone's dignity as well. That's very important. So again, when we're approaching continence issues, it's not just the answer that we think is appropriate as therapists. We need to talk to our clients and make sure that they're thinking the same way that we're thinking, and that if they can not understand our rationale, but we actually get them to the point where they do understand our rationale behind advocating it, sort of using continence products. But also using regular appearance to maintain bowel regimes and making sure constipation is not a problem, all those sorts of things. Blood pressure regulation becomes very important. And we know that there's lots of autonomic nervous system involvement with these diseases where blood pressure regulation becomes particularly problematic. And sometimes is quite hard to manage. So we might need to keep an eye on it. It might be a case if you've got a patient on the ward that we get the nursing staff on the ward to check for postural drops in blood pressure. So doing as best you can, a lying, sitting blood pressure usually. If a doctor comes along and says, oh, a bit of postural hypertension, pop some head stockings on, that'll fix it. Might fix it while you're in hospital and you've got a nice strong nurse who can get the stockings on. You discharge someone home. Have you ever tried to get head stockings on? Really hard work. Yeah. So make sure the interventions that we put in place are actually sensible as well. Head stockings can work beautifully for postural hypotension, but for the most part they're uncomfortable to wear. In summer they're hot, and carers find them hard to get on and off. So it might just have to be put some more strategies in place about, okay, you will probably feel dizzy when you go from lying in your bed to getting up, so we need to put some interventions in place. That might be do things slowly. Increase your fluid intake where you can. Don't sleep lying flat, sleep in a semi-recumbent position. Small frequent meals instead of large meals. Don't get constipated because straining is going to worsen constipation. Straining will worsen that propensity to actually drop your blood pressure. Emotional support, really important. Often use of neuropsychology to assess for those mood and personality changes. If you've got behavioural issues coming into play, neuropsychology are often really important also in putting in some behavioural management strategies. Because often medications you might use that are mood modulators aren't so appropriate in these illnesses. Social work's very important in that prolonged counselling, but also with that practical assistance, making sure that people are getting the right benefits, that we can link them into services as they need to, and that social work might have to sometimes look outside of the normal service structure to actually find services. And usually these clients will take a lot of services that are often hard to find as well. So that sort of support is really, really important. Some people advocate support groups. For these orphan illnesses, they tend to be quite small and often meet infrequently, and certainly are not, they're fraught with some difficulties, but I think support groups have a very important role. But before we refer someone off to a support group, we need to make sure that if they're just diagnosed, that they're aware that there might be people who might have quite advanced illness who attend the support group as well, and so they're not too confronted. And using carer support agencies so that they can actually link carers into services as appropriate. So in Victoria, it would be clicking into Carers Victoria, and that's actually a peak body for carers as well. And I think the statistics, I think 1 in 4 people have some sort of caring responsibility. So Carers Victoria and Carers Australia actually provide a great voice for those carers as well, at not just that practical support level, but also so their voice is heard at sort of governmental